to invite Dr. Rohit Shetty, who will be talking on collagen imaging and its role in refractive surgery planning. And this is a very new topic. Many of you all may not be familiar with it, but they have a polarizing OCT where they can actually image the collagen fibers for screening and planning refractive surgery. So it will be very interesting to listen to his work using the polarizing OCT and collagen imaging.
Thank you, sir. And talk is the imaging the collagen. These are my financial grants. I don't have any direct link to the presentation today. The evolution of refractive surgery started with different technologies, and that involved different indices. And every new year, we come out with a new indices which says that that's going to be better than the previous ones. But the challenge is still we are falling short, even though when we publish, the sensitivity and specificity of a lot of them, including pentacams, close to around 90-95%. And all the senior refractive surgeons in this panel here would agree that most of the ectasias they get or the challenges they get at once where they had a normal indices. So that becomes that suddenly you start rethinking about those sensitivity and specificity of these things. And times when you have done cases on topographies which probably would not have dared to do it today with all these indices in the what you did it in the past, you feel that they are the ones who are doing very well. So this whole challenge makes us to understand that there has to be something else, and the biomechanics makes it even more confusing. And there are small skiving, there are biomechanical changes. Sometimes there is skiving and there is no biomechanics changes, and the indices in both these cases could be normal. So we also have challenges when we do, say, cross-linking or smile extra and these procedures, when we don't know why some patients do very well and some patients actually fail. And there again, we need indices or things which can predict what is really happening. So what we thought is when we build this polarization OCT, which is looking at the collagen fibrils itself directly, what you normally see on a histopathological aspect of it. And the reason is it was important is that we need to understand the fibrils. We need to check at real time what is happening to these fibrils. We need to look at the layer of Bowman's. We need to look at every structure as it is based on what a histopathological aspect of it or what we are born with. So these are the existing modalities of it. Confocal microscopy does not give it, the resolution is not good. Scanning electron microscopy is not possible on a live imaging. And what we thought was, if we are using the principle of a polarization OCT, and that's what we thought we would like to build in. And there is a huge knowledge gap, which I already mentioned. And it took us close to 6.5 years to work on this and come out with this prototype machine where we are able to look at the properties of the collagen and using the birefringence properties, what we are aware of. What's interesting here is this is still a prototype, but we are in the process of making it commercial. It is the finest resolution possible on any OCT, humanly possible. It's close to around 1 microns. Importance is if it becomes less than 1, which is our vision and dream this year, then it becomes adaptive optics. Then you can see every cell on your cornea, keratocytes. From the retinal point of view, you can even see the rods and cones. So the whole idea is to bring it less than 1. For that, the adaptive optics has to be fit in. And the best OCTs today, OptoView or Heidelberg, is still around 5 microns. So that's the resolution change we are. The important thing is that every layer by layer, including Bowman's has a resolution in pixels of around 2.5, 3 pixels. So because of that, your resolution has to be so good that you should be able to pick up and map the Bowman's. And stromal thickness and every other layer can be checked. And this is your Bowman's layer. You can map Bowman's topography itself can be planned. And Bowman's, we all know how important it is. especially in these practices when, along with epithelium, this is one of the first layer to become thinned out. And the collagen fibrils suddenly start becoming more clear because, the darker the shapes, your more tighter orientation, the properties remain stronger. And these are your peripheral anchoring fibers, which you can do. It just takes around 1.5 minutes to image both eyes. And now we have our own software. Now, how does it help? It is that this is normal. The checkered pattern is perfect. The peripheral fibers are healthy. In a case when you see that is suspect, you can see that this lighter turquoise blue means that you have lost the collagen there, and there's only central island left, and the peripheral fibers, anchoring fibers, are also weaker. And every grade of keratoconus, irrespective of grade on your topography, you have different functions on the corneal plane. And very interesting feature here is that we can start looking now at different layers. That means you start at 90 microns, 100 microns. Your collagen imaging can be at every layer. You can just go by around 2233 microns. And this is very interesting. You can just see the smile and the PR case, the pre-op and post-op. The smile has a small change. The LASIK, the huge amount of change in the collagen at depth below 130 microns. But PRKs, especially in those cases, PRK to begin with had very poor collagen. And that's the reason you do PRKs, and you hardly see any change in the collagen. And this is pre-op smile, and post-op hardly we see changes in the collagen. So these are direct proof that when you do procedures, different procedures, and how much does it actually affect your collagen. So in nutshell, the collagen imaging is going to change a complete new dimension. And I keep quoting Dr. Sri Ganesh's paper, and he and Sheetal Brar had that big number of series of Smile Extra. But when you have a clinical paper, you need proof. And recently I was presenting in the Smile Users Meet that the collagen changes after Smile Extra was completely different compared to what you do with just Smile. So just that when most of your clinical data needs proof, and all that you've been doing, the imaging the collagen helps you to get that proof. And this is a non-invasive technologies, and maybe next year the same technology will be able to image the keratocytes, many cells in your cornea, and every layer would have different patterns to it. And this is a big biomarker, maybe even in planning procedures. And also sometimes when you have these unexpected outcomes, especially in cross-linking, when you get a scar and other things, excessive collagen, if you have, and you do a cross-linking on it, you get scarring. This is what we have noticed. And this also can help us to decide when we need to do a LASIK or a Smile Extra, or you can just ignore it in spite of corneal topography being abnormal. And we are working with 2 companies, and a lot of OCT companies are interested because they want to, this will be the way they would look at the next version of OCTs on this. And this is the fibril orientation. Now, this is a software we built which looks at the complete fibrils as it is from the corneal plane. Thank you.
Thank you, Dr. Rohit. Very interesting work that you are doing. I think this is more significant for countries like India, where our average refractive surgery patient's age is around 26 years, compared to the Western countries where it's 36. And we all know that with age, the collagen changes and gets cross-linked, so it's a little stronger. So probably the risk of ectasia in countries like ours, where we are treating a very young population, would be much higher. So that's where devices like this can provide us insight, where we are actually able to image the collagen.
And like I said, your work on excellent work on Smile Extra, when we started doing this, where we did a randomization, it exactly proves what you have written in your conclusion, in your discussion, that it biomechanically changes, and this is a proof. So whatever we say, we need proof, and the proof is when you see this image, like I showed, those orientation completely changes.
So what do you think would be the cost? Because now we have so many devices for pre-op assessment, so it's becoming, the pre-op assessment itself is becoming more expensive.
So it will be cost of your OCT or topographer. It should not be more.
It should not be more.
Because they just need to have a different hardware. It's better for them because with the present hardware, they're not even reaching 5 microns resolutions. Yes. This is going to 1. And if you add adaptive optics, it's becoming costly. But that's why Oculus is very keen, because all the companies which wants to make the new OCTs are very keen on this. So I have no doubt that this should be the next generation of OCTs. This will be the source of light.
Many of the institutes have confocal microscopes. Is there any way to image collagen? No, it's very difficult. You can see cells and...
it just looks at the cells because the resolution is poor. And no way you can measure it. So the only way to measure is the scanning electron microscopy, but that's not possible. It will burn the whole eye. The second way is the non. It just takes exactly 90-95 seconds per eye. And software we have only developed it. So, but I'm sure the companies will do their own as we go on.
Congratulations.
How sensitive and specific would be the...
We just published in JCRS. It's very high, close to 90%. Repeatability is very good. It was just published 4-5 months back.
And is it going to be like a whole new language, or anybody can interpret the data that is given?
Anybody can interpret it. I just showed you. It's just color-based.
Thank you.
Thank you.